Next one here is from Ovi, who says, how do you propose to reverse more advanced cases with this new SARA approach? So what I've proposed in the past is that we look at some point at what I've been calling SARA, severe Alzheimer's reversal attempt. And this would literally just be a couple of people at the beginning who have single-digit MoCA scores, because on our trial, the initial trial was 19 and above. This new trial is now going to be 18 and above. But there's no question, it's harder to turn things around with people when they have a single-digit MoCA score. And so there are other things, though, that are now available. We can look at, stem cells, plasmapheresis, IVIG. There are all sorts of intranasal peptides. So there are things that can be addressed. And again, looking more closely at what's actually driving this. Then he goes on to ask about stem cell treatment and plasma treatment. Yeah, I think these are all going to be part of what will be used for people who are further along. And he says, what is next after the demise of the amyloid hypothesis? Well, there are amyloid hypothesis people who are saying that it's still a viable hypothesis, and they're doing more and more trials, and maybe one of these trials will be positive. I think that this is sad because trial after trial after trial has shown that this hypothesis simply is not a viable hypothesis. Now, I understand one of the pushbacks has been, well, it will work when we just start it early enough. Maybe, but even the ones who have started it early, the best they have seen is a minimal slowing of decline. No one's ever said, whoa, we cured somebody by getting rid of their amyloid. So I think it's pretty clear from many, many different angles that this is a hypothesis that has simply not been predictive of what does and does not work. And Ovi's asking here about inflammation. Yeah, well, the next hypothesis is what we've published repeatedly in books and papers. This is a network dysfunction, a network insufficiency that has dozens and dozens of components, very much like a precision medicine or a functional medicine approach. And then Ovi mentions the first case of a cure of HIV/AIDS was just publicized. Yeah, great point. And that's 30 years after the initial treatment. And this, remember, HIV is simple. It's a virus. We know it. We have sequence of it. We know exactly what it is. That's a simple illness, one virus. When we're looking at Alzheimer's, it's a complex chronic illness, much more complex than a single virus. So yes, we need to understand there's still great disagreement about what this represents. So and I should say the SARA trial, this is down the road. We're currently involved with an RCT, with a randomized controlled trial that Dr. Hathaway is involved with and 5 other clinicians, set to start later this year. I'm very excited about it because there are all sorts of new tests and treatments. So I think that this is going to be very definitive in showing that, yes, we can do this, and we can now see better and better the improvements, just as we saw in the previous trial without a lot of these new tests. So I think that this is going to be helpful. And then doing these things, potentially in an assisted living facility for those who are far along, so that you have control over the diet and over the the environment and so forth, just like Marama. So I guess the question would be, Anne, for your patients who come in and who have single-digit MoCA scores, what do you recommend for them?
Well, first, I do want to say that we have cured Alzheimer's, right? You published 100 cases. Our paper, we had an 80% success rate in reversing MCI and early Alzheimer's disease. I expect that we're going to have success in the next study. Yeah. So when people come in, usually it's someone who's very impaired with their spouse or someone who's very impaired with another family member. I do caution them that when people are far along, we do not have as high a success rate as we do with early Alzheimer's. I need to set people's expectations realistically in those cases. But sometimes we do see significant improvements, not all the way to normal, but we do. I have seen in at least 3 or 4 cases, people with MoCAs below 15 who improved significantly, and one person with a MoCA below 10 who improved some in terms of a noticeable to the family kind of improvement in their functionality and their ability to interact and enjoy life. So it is worthwhile to pursue it, but I think it is also important to set realistic expectations for people.
Yeah, and I think it's important to point out when you talk about realistic expectations, if you go to an expert center, you will be given a drug, and you will continue to go downhill. And that's happened again and again and again and again. And the quote best centers in the country are having no success with reversing cognitive decline. What has been lauded as success for donanemab and aducanumab is a slowing of the decline process. You still decline, you still don't get better, you still don't stabilize, but in the best case scenario, you may decline 22% less quickly on aducanumab, 32% less quickly on donanemab. So it is a tough situation, and we're all trying to get better and better outcomes. And I think that the good news is with additional testing, with some of the new modalities, we should be able to get even a better handle on this and see who's going in the right direction more quickly, kind of real-time looks at things with things like some of the electrophysiological measurements to continue to optimize things. I'd love to see it so that virtually everyone would improve.